Hello, my name is Brenda Suggett, and I'm the Executive Director of the Canadian Association of Road Safety Professionals, or CARSP. And I'd like to welcome you to today's webinar entitled Drug Recognition Evaluation for Impaired Driving by Drug. And I am joined today by Sergeant Shannon Gordon, who is actually one of our board members. So we're in for a real treat. She's with the Regina Police Service, and she's going to tell us about her job, basically. But before we get into that, I do have a couple of announcements. So first of all, we do have a webinar coming up at the end of February. It is going to be on the 24th between 12 and 1 Eastern Time. And the topic, it's going to be Matt Pinder from Mobicon, and he's going to be talking about traffic calming on arterials, why it matters, and how to do it. And the objective of that webinar is to educate practitioners on why speed management on arterials is important and techniques for achieving it. So we will get that posted by the end of the week. So please keep an eye for that webinar announcement. The other thing I wanted to make you aware of is today we have just launched our call for co-hosts for the CARS Conference 2027. And we sent it out through social and also through LinkedIn as well, through our email distribution list. It's also on our homepage under the news section. And this is inviting different groups, whether you're a government group or a nonprofit or a private company who might be interested. We do partner with different groups. We've done this a number of times over the year, and it gives you a chance to showcase like what road safety initiatives and programs and things are happening within your organization or your particular geographic area. And it really puts you, head first, top of the line in the road safety arena. So there's a lot of benefits to co-hosting, and I do encourage you to go and read that RFP and to submit your proposal. The deadline for that is February 25th. The other thing I wanted to just remind people about is the fact that we do record all our webinars and we make them available in the same area where you actually sign up for a webinar. And the most current one is only available to CARS members, but any past ones are available to the public. And once again, just a little promo for CARS membership fees. They're $125 a year, and you get access to our monthly webinars, including the recordings. And we just encourage you to share those links with your colleagues, with your networks, if you know of someone who would benefit. And again, there's a number of the webinars that are available to the public, so we do encourage you to share them with your colleagues. Now for quick housekeeping information. So we do a post-webinar survey at the end of every survey, and Homa, my assistant, is going to be placing it, well, she already did, into the chat area. And it just takes a few minutes. It gives our speakers some feedback. It also helps with any future topics that we want to learn about that you'd like to see. So please, we encourage you to fill that out. And as an added incentive, after each 3 webinars, we take all those names and we draw one person's name to get a Tim's gift card. So there is a definite bonus to doing that. The other thing I wanted to mention is that we do take questions for the webinar, but we do so at the end of the webinar. But you can place those questions at any time into the Q&A area at the bottom of your screen. So I invite you to do that. And now, without any further ado, I'm going to introduce Sergeant Shannon Gordon. She began her policing career in 2001 as a special constable in the detention unit with the Regina Police Service. After attending the Saskatchewan Police College in 2002, she gained extensive experience across numerous areas, including patrol, vice, robbery, drugs, property crime, human resources, and traffic. She also completed a 2 year secondment with the RCMP's National Drug Impaired Driving Evaluator Standards team based in Ottawa. She's a certified drug recognition evaluator, or DRE, as we're learning about today, since 2007. She has trained hundreds of officers across Canada and is currently the sergeant in charge of the traffic safety unit at Regina Police Service, where she leads efforts to detect impaired driving and promote road safety. Road safety has been a passion of hers for her entire career, and she is committed to working in partnership with other community stakeholders to keep the roads safe. She was raised on a family farm southeast of Regina, and she credits her 4-H roots for instilling a strong work ethic, community spirit, and sense of responsibility. She has served on several boards and committees, including the PAC Program Project Dog Rescue, CARSP, as I mentioned before, and Saskatchewan Women in Policing. So, welcome, Shannon, and I am going to turn it over to you. And we can see your screen just perfectly.
Okay, great. Thank you. Welcome, everyone. I'm trying to condense years worth of experience and knowledge in this field into a reasonable amount of time to make sure that we have time for questions. So basically we're going to talk about impaired driving and police investigation into that, if you're not familiar with it. And then we'll talk about the role of a drug recognition expert in proving impairment for drug and alcohol. So obviously one of the big things is how big is this problem? Everyone in this field recognizes impaired driving is a big problem in our country and remains one of the big problems. So statistically, there's about 9 charges per hour, for alcohol or drug impaired driving. 459 Canadians have lost their lives within 12 months of being in a crash where or involving a drinking driver, and then 496 Canadians were killed in crashes on public roadways involving at least one driver who was positive for drugs. So although we know alcohol is a problem, we're starting to see that increase in drug impaired driving, where we're now at 496 as opposed to 459 with alcohol. And so it roughly works out to about 4 deaths a year, or 4 deaths a day are caused by this problem, which is staggering. So like we talked about, impaired driving by alcohol and drug is the top criminal cause of death in Canada. And alcohol-related fatalities, like I said, had decreased, but we're starting to see that increase in drug-impaired driving now as more officers are being trained at identifying and articulating it in courts, and as drugs become more of a problem in the driving population as well. So when we look at the impaired legislation, 2018, we saw a sweeping change through our impaired legislation. One of the big ones was before we had operation versus care and control, where care and control would be you may be, say, sleeping it off behind the wheel, but you have the ability to put that vehicle in motion, so the keys are available to the driver. Whereas now, the legislation has combined those two together, and operation includes care and control. So there's really no difference anymore. Conveyance, we saw motor vehicle definitions change a little bit. It's now defined as a conveyance, which includes a motor vehicle, vessel, aircraft, railway equipment. So for motor vehicle, it is any vehicle that is propelled by non-muscular ways, as opposed to a vessel or a watercraft, where you could still be charged with impaired if you were in a canoe, kayak, because that definition does not exclude the muscular power like a motor vehicle does. Location is one of the other things that police have to prove for the offense when it goes to court. And in impaired driving, that's made pretty simple that it can be absolutely anywhere. It can be on private property, parking lots, in the middle of a field, pasture, middle of a lake, anywhere in Canada, it is illegal to operate a conveyance while the driver is impaired. And then impaired, we saw a bunch of different definitions for that when it came to when it came to court documents and how each court was defining because it wasn't clearly defined. And so we've now seen that impaired is now defined to any degree. We used to have things like any degree from slight to great, a marked departure from the norm, and so on. Now it's to any degree. So that whether that's minute or large gross impairment. So when we're training our officers on how to detect the impaired drivers, we kind of break it down into three phases. So phase one, we term vehicle in motion. And so it's just all those observations that are gathered while that vehicle is driving, whether it be a violation, whether it be a swerve in the lane or a weave in the lane, whether it's headlights not on, one burnt out headlight, whatever drew that officer's attention to that vehicle, we want to start our investigation right at that moment. And then that continues as the officers are following that vehicle, they may see more evidence. And we will always remind them that at this point, or at every one of these phases, there's three questions that they want to ask themselves. Do they act now? Do they wait? Or do they let that vehicle go? And so if someone was showing gross impairment and it was becoming unsafe to allow them to continue to drive, obviously they're not going to continue to follow. They're going to stop that vehicle immediately. And this vehicle in motion may be very short observation period, as opposed to someone who is maybe weaved in the lane and officers just trying to determine, was it a momentary lapse in concentration that caused that? And so they may continue to follow them, or they may just decide that there was something in the roadway that they swerved around a pothole or something else in the roadway, and there is no need to stop them. They may let them go. The next phase is, and that phase concludes as we watch the vehicle pull over to the side of the road. So when we activate our lights and sirens, and we're watching that vehicle pull over, there's standard ways, I guess I'll say, for lack of a better term, of how we all sober pull over to the side of the road. We usually don't bump the curb. We usually pull over appropriately to the roadway, not on an angle. We're usually onto the shoulder, not all the way into the ditch. So we ask our officers to continue monitoring the motion of that vehicle as it pulls over and comes to a stop. Then they switch into their personal contact phase, which is, again, continuing to gather evidence as they approach that vehicle and they start to interview the driver. And at that point, they're using a lot of their senses, their sight, hearing, smell, and being able to ask the driver those questions and really pay attention to some of those subtleties that can come from even low-level impairment. And then that ultimately will lead them into phase three, which would be their pre-arrest screening. So where they're still at reasonable suspicion to believe an offense is being committed, namely impaired driving. And at that point, they have three tools to help them. So they've got the approved screening device, the standardized field sobriety tests, or an approved drug screening equipment. So either they can do alcohol testing roadside, they can do oral fluid testing roadside for recent drug consumption, or they can do the standard field sobriety, which will show impairment for both alcohol and drug. And that, depending on the results of those tools, that can elevate them to reasonable grounds to believe, and therefore they can make an arrest at that point. So when we talk about impaired to any degree, with the new changes in the criminal code, we now have 2 hours. So within 2 hours of ceasing to operate a conveyance, the blood alcohol concentration is deemed to be the same as it was at the time of driving. So if reasonable grounds to believe that the driver committed an offense under the impaired legislation within the preceding hours exist, then an officer can arrest that person and bring them to the police station for further testing. It's very opinion-based evidence and is based on the totality of the circumstances in all three of those phases. If more than 2 hours has passed since the driving, when we get our blood alcohol concentration, the courts have, or the criminal code has now given us the elimination rate calculations that for every 30 minutes outside of that 2 hours, the body eliminates 5 milligrams per milliliter. So if someone, say, blew 90 milligram percent in for a breath test, and it was outside of that 2 hours by, say, an hour, we would simply add 5 milligrams for every 30 minutes that has passed outside of that. So they would actually be at 100 while they were driving. Before, we used to have to call a expert to come testify to that, and now we've been given the ability to do that math ourselves. So once they've developed their reasonable grounds to believe and made their arrest, there's a few different things that they can do. So just standard breath demand, which would be that they are brought into the police station, given their breath demand, and they provide 2 suitable samples. And then, like I said, as long as it's within that 2 hours, that is deemed to be their blood alcohol concentration at the time of driving. Outside of that, we just simply do that equation. We can also do a blood demand if the driver is unable to provide a breath sample. So perhaps they're in the hospital. We can certainly do a blood demand as well and get blood drawn from the person for analysis as well. And then obviously we have our blood warrant as well. So if someone is unable to consent to giving blood and they are unable to provide breath because perhaps they're unconscious, which would be why they can't consent or why they can't agree to the blood demand, then we can do a blood warrant. And if a judge believes that there is reasonable grounds to believe, they can swear that warrant and we can draw blood. So what happens when it is not alcohol? When an officer pulls somebody over and they have no indication of alcohol, but that person is appearing to be impaired, how does that officer then proceed from there? So with the new legislation, we were given one new tool, which is the drug per se limits. So we now, just like we have per se limits that at alcohol, or for alcohol, if it's 80 milligrams and above, that is a separate charge for exceeding the per se limit, and then the impaired charge would come from the other evidence gathered from the driving action. When it comes to the drug per se limits, we now have these limits that it is statutorily prohibited to have in your system when you're driving. So, for instance, THC, 5 nanograms per milliliter of blood, GHB, which is a depressant, 5 milligrams per milliliter of blood, lysergic acid diethylamide or acid LSD, any detectable level, psilocybin, which is your magic mushrooms, are any detectable level. Psilocin is also a hallucinogen at any detectable level. We have 6-MAM, or it's a metabolite of heroin, and PCP, ketamine, which is a dissociative anesthetic. It's traditionally used as a large animal tranquilizer, but is also being used currently for burn victims. And there is some promising research and use happening for treatment of PTSD. And then cocaine and methamphetamine, any detectable levels. So if officers believe that the driver may be on one of these drugs, they can do a blood demand. get the blood drawn, send it away. If it comes back as any higher than these levels, we can charge and exceed charge. The I guess interesting thing about this is obviously drug impairment is not at the research level that alcohol impairment is at. And so with alcohol, we can scientifically back up that at 100 milligrams percent, you are impaired. And so often we will see the two charges coupled together. If they blow 100 milligrams or higher, they're often charged with exceed and impairment by virtue possibly of just being above 100 milligrams percent. With drugs, weird science isn't there yet. Hopefully it will get there, but right now we can't say that at any of these levels the driver is actually impaired. So if we're going to go this route, the driver would potentially be charged with exceeding the drug per se limit, and there would be no accompanying impairment unless there was evidence to support that on its own. So, how do police improve, or how do police prove impairment when it comes to the driving of or the driving actions of these offenders? So that's where the drug recognition expert comes in. Pardon me. So it is a 12-step standardized systematic investigative process. It's governed by the International Association of Chiefs of Police. So a DRE evaluation is the exact same anywhere in the world that has them. And it has a technical advisory panel that reports to the Traffic Safety Committee of the IACP. And that technical advisory panel is made up of a variety of expertise in the various areas of a evaluation, and they're constantly reevaluating and updating and keeping the program and the evaluation current. So how do you become a drug recognition expert or a DRE? It's 2-week intense classroom training. Then there is a written exam at the end of that 2 weeks. On successful completion of that, there's a 1-week certification training that happens where the students are doing evaluations on live drug impaired volunteers. And then there's a lengthy written exam that follows that, followed by an oral exam. That written exam most commonly takes about 8 hours to write, sometimes up to 12, depending on how much the student writes or how quickly they write. But generally, it's around 6 to 8 hours, and then followed by an oral exam with 2 instructors following that. So the process itself, like I said, it's a 12-step evaluation that is conducted and interpreted by a trained evaluating officer. That 12-step process includes questioning the arresting officer, some questions for the driver right off the hop that help us to determine the possibility that maybe this is a medical impairment as opposed to drug or alcohol. Perhaps there's something else going on. And then followed by some eye tests where we're looking for what we call horizontal gaze nystagmus, which is an involuntary jerking of the eyes as the eyes gaze to the side. And that can be caused by particular drug categories as well as alcohol. Then we go into some psychophysical tests or divided attention tests. We all know driving requires divided attention. We're constantly assessing our surroundings and dividing our attention on what's going on around us. So the psychophysical tests are designed to be simple enough, but require the person to divide their attention, much like driving requires. Then there's blood pressure tests, pulse, muscle tone, body temperature, an examination for injection sites or methods of ingestion, as well as examining the pupil size in 3 different lighting conditions and the reaction of the pupil from near total darkness to a direct light, and watching what the pupil does. It's supposed to obviously close down rapidly, like it would if we turned a light on first thing when we wake up in the morning and it's dark in the room. And there are certain drug categories that prevent the body from doing what it's naturally supposed to do. So at the conclusion of the evaluation, they'll be able to provide evidence of the impairment, as well as identifying what drug or drug categories are, what drug category or categories are causing that impairment. And then remaining a DRE, we are required to do a minimum of 4 evaluations. That should be every 2 years. 1 evaluation that is witnessed by a DRE instructor, a minimum of 8 hours of continued education, and then we submit our updated CV to our national oversight for review and approval. So currently, these stats are a little bit dated. We're a little bit higher than this, but there's approximately 600 active DREs across Canada. When the program came to here in the early 2000s, since then, approximately 1,500 have been trained. However, a lot of them have transitioned on into other areas of policing where the skill is not being used and they're unable to maintain their certification. And interestingly enough, the Canadian Centre of Substance Abuse recommends that we should have 2,000 to 2,200 DREs, and we are significantly below that. So that's our goal as we move forward, is to increase the number we have to better combat what's happening on our streets. So there's 7 categories that the DRE looks at. So central nervous system depressants, inhalants, dissociative anesthetics, cannabis, central nervous system stimulants, hallucinogens, and narcotic analgesics. And so there's a bit of a misconception in some of the policing world about what a drug recognition expert is. And I'll often get officers bring, a pill to me and say, "What kind of pill is this?" To which I say, "I'm not a pharmacist. Take it, come back in 20 minutes, and I'll do an evaluation and tell you." Like we're not trained to recognize a drug. We're trained to recognize the category of drug and what that category, generally as a whole, is going to do to the body. And that's how we determine what somebody is on, not by looking at what drug, what pill or fluid or whatever they may have on them. So this is our drug recognition expert matrix. This is kind of our bread and butter, our little holy Bible of the DRE world. And you can kind of see how each, as we go through those categories, those major categories that we have, how each one causes something different for the eyes. So if we were to look at reaction to light for a central nervous system depressant, inhalant, or a stimulant, we can see that that slows the reaction to light. So when we take them from near total darkness and we shine that light in their eyes, we're going to watch that pupil slowly close, as opposed to something like a dissociative anesthetic, cannabis, or a hallucinogen, which would be a normal reaction to light. And then we have a narcotic analgesic, which there, as you see above, the pupil is already constricted. Even in near total darkness, it will be very small pupil size. And so when we shine that light in the eye, the pupil really has nowhere to go and produces very little reaction to light. So this is kind of the matrix that we use in determining what category a person is on, or categories. And then in conjunction with this, because it's a totality of the investigation that the DRE is doing, we also look for what we call general indicators that are somewhat specific to each category with some overlap. And so their DREs are trained to recognize and interpret what they're seeing through some of these general indicators, as well as our matrix to identify the category or categories that a person is under the influence of, and then be able to explain that to the trier of facts or the courts. So when we look at central nervous system stimulants, these are things like Ativan, Xanax, Valium, Prozac, Benadryl, Dramamine, GHB, secobarbital, xylazine, which we're starting to see come back quite a bit, Wellbutrin or bupropion. Um, and they're all going to produce just like alcohol. Alcohol falls in this category as well. So they're going to produce a lot of the same things that we would normally see in alcohol. And so sometimes we see officers bring someone in that they think is impaired by alcohol. They put them on the breath instrument and they blow a very low level alcohol or no alcohol at all. And it leaves the officer scratching their head saying, well, what else is going on? Highly likely that they are looking at some other form of a depressant that is presenting the exact same. And at which point they would then do a DRE demand and call a drug recognition expert in, and we would do our evaluation and determine whether or not their ability to operate a vehicle is impaired. So the other one is inhalants. So these are usually, glue, acetone, paint thinners, nail polish remover, hairsprays, freon, amyl nitrate, nitrous oxide, or laughing gas. It's not overly common in our driving population, but it does happen. We have had a couple here in Regina that we have seen, but they generally are producing headaches, usually vomiting, um, dizziness, flushed face, high pulse, watery eyes, that slow, thick, slurred speech. The other one we have is dissociative anesthetics. So these are things like PCP, ketamine, um, DXM or uh, dextromethorphan. And DXM is obviously in our cough syrup or found in some cough syrups. It's generally found in quite a few different cough syrups. And if ingested in high quantities, it can have the same effects as a dissociative anesthetic. So generally, our officers are encountering these drivers doing increased risk taking. They have a feeling of invincibility. They have a very high pain threshold, rigid muscles, cyclic behavior, possibly violent, warm to the touch. A lot of times, these are high speed drivers, drivers who think that they can get through that amber light. They're just everything about them is wanting to take those extra risks, and a lot of the confusion that goes with them. The other one is cannabis. Obviously, we had the legalization of cannabis, so we're seeing a little bit of a rise in the use of this in our driving population. And it comes in sativa, indica, or a hybrid of the two. Pardon me. So your sativa is generally um, your brain high, a lot of creativity, um, comes from sativa, whereas indica is a little bit more your body high. It's that calming. We remember it by Inda couch. So it's kind of just that relaxing body high. And then there's the hybrid where you're going to get a little bit of both. Interestingly enough, there was a U of S study that was just done here for the University of Saskatchewan out of Saskatoon, and it's gone for peer review now. But some of the early results that they've been announcing have been rather interesting. In the For those that haven't heard about it, the participants were between the ages of 19 and 30. There were 50 participants. They were given 10 milligrams of THC in an edible, and then they were tested on a driving simulator that had a 180-degree view and a motion platform to mimic actual driving. And what they ended up finding, they tested them at 3 different time intervals, and they started to see that there was an inability to maintain the speed of the vehicle. Their reaction time was altered, and especially their concentration and ability to perceive objects in the distance. And that started as soon as 1.5 hours after ingestion. And then the part that particularly I found interesting and equally concerning was that around the 4 hour mark, 58% of the participants crashed their simulation vehicle. At 2.5 hours, 44% crashed their simulated vehicle. And at 1.5 hours, 30% crashed their vehicle. So there's some very promising studies being done that will help to show the dangers of driving on cannabis as well. So then we have central nervous system stimulants. So this is your cocaine, methamphetamine, amphetamines, uh, dexedrine, Adderall, Ritalin, generally causing hyperactivity. Generally, those that are binge using will go days without sleeping, days without eating, often exaggerated reflexes, everything sped up. So again, a lot of your speeders, disobeying red lights, disobeying ambers, body tremors, anxiety, exaggerated reflexes. So, maybe cutting a corner very sharp, increased alertness, restlessness, talkative, some of the general indicators that officers might see. Our second to last one is hallucinogens. So this is peyote, which is a variation of it's basically a cactus plant that grows in the US, and you can sadly order it through the mail. Psilocybin, nutmeg, Jimson weed, morning glory seeds are some of the natural ones. And then we have our MDMA or methylendioxymethamphetamine, LSD, so your acid, which are your synthetics. And they all produce delusions and illusions. So perhaps a delusion might be I am Superman. It's a false belief, as opposed to an illusion would be a false perception. I am or I see an elephant. They will produce body tremors, dazed appearance, difficulty with speech. Like we talked about, maybe having hallucinations. Perspiring, piloerection is goosebumps. Synesthesia is when there's a transposition of the senses. So you perhaps hear a color, you see a smell, and then uncoordinated paranoia. So obviously, we can well imagine someone who is perhaps hallucinating or in a delusion state, and the dangers of that person behind the wheel. Then our last category is our narcotic analgesics. So these are used to treat moderate to severe pain. And then they also have feelings of euphoria and relaxation that often lead to sedation. So they help to relieve pain and help a person sleep. They are highly addictive, and they produce withdrawal signs and symptoms. And kind of one of the interesting things about this category is that they will suppress withdrawal symptoms and signs when substituted for each other. So methadone falls into this category, which is often prescribed to help people with withdrawal symptoms when they're trying to quit using another narcotic. So these all, I shouldn't say these all, these essentially come from the opium plant, or the opium poppy, which, if we want to kind of consider that, it's almost like a wheat seed. And then we have alkaloids within that are morphine, codeine, tramadol. These are alkaloids of that. So almost like taking that wheat seed, grinding it down to make it brown flour. It's a direct kind of descendant of that original opium poppy. And then we've got our derivatives, which for comparison's sake, we'll call our white flour, where there's been some kind of alteration to them. They still fall within that family, but there's been some alteration to the original poppy. And so these are your heroin, dilaudid, hydrocodone, oxycodone, Percodan. Then we also have our synthetic opioids, which are obviously lab-based. Those would include Demerol, methadone, fentanyl, carfentanil. And so these, like we looked at with the matrix, all produce constricted pupils, depressed reflexes, droopy eyelids. They're tired, some drowsiness. Um, on the nod, which is a unique phenomenon to narcotics, where a person appears to be sleeping, but they're fully aware of what's going on in their surroundings. And if you were to say their name, they would be able to answer what you had asked them because they are perceiving everything in their surroundings. They're not actually asleep. And then a slow, raspy voice, which is very common in this category. And ultimately, the slowed breathing, which leads to the danger of overdoses. So when we come back to our um, matrix, you can kind of see how we would go through with our pupil size, our reaction to light, blood pressure, body temperature, muscle tone, as helping to assist in this, but then also each of those general indicators become super important to also help determine that, especially when there is multiple categories on board. And it's very common that multiple categories are being used by some of our driving population. So this would be the form that our evaluation looks like. This is the standard form used all across Canada. And it basically outlines, you can see that top information there where it's talking about whether or not they're diabetic or epileptic, if they're under the care of a doctor and seen a doctor recently, a dentist, when they ate, when they last ate and what, when they last slept. And basically, these are just helping to, like I said, eliminate whether or not there may be something else going on here that perhaps isn't alcohol or drug related. We're also looking at how does their face appear? Is it relaxed where you can picture someone who's maybe been drinking and their face muscles are just relaxed, as opposed to someone who is perhaps on a stimulant where everything's racing, eyes are wide, face may be flushed. And then we just kind of work our way through with the pulses, our eye tests, the ability to cross their eyes. There are some categories of drugs that prevent us from crossing our eyes. And then our divided attention tests, very similar to our standardized field sobriety, where we're asking them to perform simple tasks like standing on one leg while counting out loud, or walking a line in a heel to toe fashion, 9 steps, making a turn, and walking 9 steps back. Um, there's a finger to nose one where we're asking them to tilt their head back and close their eyes and touch the tip of their nose with the tip of their finger. And it's just testing spatial awareness and precision of touch. Then we move into our eye exams in the 3 lighting conditions, where we're also doing an oral exam and a nasal exam for potential ways that they may have ingested their drug of choice. And then obviously the arms there, where we're looking at injection sites, maybe bruises, whatever the case may be, we're documenting, as well as blood pressure, muscle tone. And then at the end, we're making our determination on whether or not they are impaired. And if so, a urine, blood, or potentially oral fluid could be demanded from them. Generally, it's urine. And then that is sent away to the lab to help corroborate the DRE's opinion call. So when it comes to court and holding these drivers accountable, R versus Bingley, which was a court decision from the Supreme Court of Canada in 2018, where they said by virtue of the intensive training that officers go through to become a DRE, they are able to give expert opinion evidence without a voir dire, and the courts can weigh their opinion evidence at that higher level without going through that voir dire. And then obviously court testimony that happens where we walk the courts through exactly that matrix and what we're seeing for general indicators, and how different drugs interact with each other, and ultimately with what the body is trying to do naturally. So just a perspective here from Saskatchewan. In 2024, we did 51 evaluations, and the most common at 21 of them was stimulant and a narcotic used together. So the kind of brown section there on those pie charts is that poly category, so more than one. Obviously, that, like I said earlier, it's very common for more than one drug to be used at a time. And then as far as our single calls, cannabis and narcotics, cannabis, there was 6 charged with straight cannabis use and 6 charged with narcotics. In 2025, our evaluations went up to, we did 65 that year. Most common, again, was narcotic and stim. We see a lot of cocaine, fentanyl combinations here in Saskatchewan. And so we had 33, followed by just a straight narcotic, only using the one drug. There was 6 of those calls. Cannabis only, there was 3. Cannabis in conjunction with something else, there was 6. So we are seeing that rise in cannabis use and cannabis in combination with something else. And then this year, we're only January, and we are on pace to well exceed that 65 evaluations this year. I think we've already done 20 something in the first month of the year. And that is it for me. I'm going to leave you here with a picture of my lovely babies, because dogs bring joy to my life and they're my little hiking partners. So the big Great Dane is Freya, the little Corgi is Olive, and the little black one is Bella. And they said they bring me joy. Hopefully they've brought you joy today.
Thank you so much, Shannon. That was an
Yeah.
excellent presentation. It was a great overview. Wow, a lot of different drugs for sure, and a
Yes.
lot of different effects. And yeah, that's wonderful that uh, there are people like you that are willing to go through that extra training and to stay with it too, because I know it is a tough role. So thank you for giving us a glimpse into your life
Yeah.
and what that's all about. So. Without any further ado, I'm just going to look over at the questions that have come in. So,
Mm.
one person said, those dogs look high on life. So, that's just a
They are.
comment. Okay, so now for some actual questions. So, one is you said the legal limit for alcohol is 100 milligrams, which would equal, I guess, zero point 0.1 in terms of the per se limit. But I think it's, correct me if I'm wrong, zero point 0.8 in the criminal code, so, or 80 milligrams.
Yeah. So within the
Yeah,
criminal code, it is 80. The
okay.
presumption that you are impaired at a particular level is 100. So if
Okay.
someone perhaps blew 90, we wouldn't necessarily be able to lay that impaired charge with that. Whereas if they blow 100, even if they came into a stop check and we had no driving evidence, we could still lay that impaired charge because we know that at impaired or at 100, you are impaired, even though our legal limit is 80. So at 80, you could possibly only be charged with exceed, if that makes sense.
Well, yeah, so is that all based on kind of what is held up in the court system?
Yes.
It- okay.
Yes. Yes.
Okay. It's
So
more.
and vice versa, you could be charged with impaired if say you came in and you blew 60. You may not be, or 0.06. You may not be charged with the exceed, obviously, because you're not over 0.08, but there may
Right.
be evidence to support the impairment. So they're separate charges, but at 100, they can be laid together based off of that reading.
Okay. Okay. Thank you for clarifying that.
Yeah.
So yeah, and someone mentioned that there was no per se limit with respect to MDNA,
Yeah.
and just wonder if that is the case.
It is the case. It is,
Oh,
which was surprising to me too when they came out. A lot of them there was no medicinal reason why a particular drug should be in your body, with the exception of perhaps THC. But medically, no doctor is going to prescribe you cocaine. But
Okay.
there are, and really, other than some of the microdosing that's happening for various illnesses, where there's some um, positivity being shown for some hallucinogens and with ketamine, but really there's not a lot of medicinal reason for you to have MDMA, and yet it wasn't included, which I found interesting as well.
Okay, great. Thank you. Another question is, are any drugs that are more likely to have people just be honest that they are high?
Good question. When dealing with police, no. um, Most are not super forthcoming on anything that they've ingested. Um, but I would say all of them, because majority of them do relax inhibitions. A lot of times when we get talking to people, things will slip that they've done. So not really a drug that really causes that, other than, like I said, that relaxation of and yeah, decrease in inhibitions.
Okay, thanks. Um, okay, this one's about DREs defending in court.
Mhm.
How often is that required? And are their opinions usually accepted and upheld? I know it's a big
Yeah,
question.
they are. I know every province is a little bit different when it comes to their courts. Here in Regina, uh, a lot of our DREs don't testify as often as you would think. A lot of
Okay.
times, the accused will wait and see if the evaluator is going to show up. When we do, they usually will enter a plea and just plead guilty. Sometimes it will go to court, but it's not very often. Whereas other provinces, I know some of the Ontario DREs spend a lot of time in court. So I think it just depends on your region. But across Canada, our opinion-based evidence has been held with high regard in the courts, and has been used to help convict the drug impaired drivers.
Okay, perfect. Thank you.
Mm,
Yeah, and I have another question to do with measuring pulse and blood pressure.
mhm.
And he was mentioning, that it can vary according to, the time of the day and without knowing the baseline level for that driver, for instance, as well. Like he was just wondering if you could be more specific about your approach to using both pulse and blood pressure in your determination of impairment.
Yeah, so basically, how it is viewed with us is, when you look at almost like a bell curve of general population, obviously you're going to have some of those outliers on the edge, and so most of our people fall kind of within that more top portion, but there are people that are going to fall outside of that. And so we use the pulse rate of 60 to 90 beats per minute would be, for lack of better words, considered normal in a DRE evaluation. However, um, just because you're at 60 or you're at 58, 54, doesn't in and of itself say you're on a particular category. Um, as for blood pressure, for systolic, we use 120 to 140 milligrams of mercury over the diastolic of 70 to 90 milligrams of mercury. And so general population will fall somewhere in there or slightly just outside. But again, if everything else was showing relatively normal and you had a high blood pressure, that in and of itself would not um, prove impairment by any particular category. It would just be you may have high blood pressure or you may have low blood pressure. And so it's all taken within that totality of everything. Same with temperature, we use 37 degrees Celsius plus or minus 0.5. So again, our bodies try to keep us at a relatively stable temperature, but everyone could be a little bit outside of that one way or the other.
Okay, perfect. Thank you. And by the way, you're getting a lot of great presentations, excellent presentations, comments in the chat area, just to let you know
Well,
about that.
thank you, everyone.
Um,
I'll send your check in the mail.
yeah, yeah, yeah. Yeah, so one person wondered, as new synthetic drugs come along, do you
Mm,
get refresher courses? I know that you guys do have like an annual DRE conference. So yeah, maybe you could just comment on that.
yeah, so there's two kind of gold standards for our continued education training. And that is one conference that the International Association of Chiefs of Police put on, travels across the US every year. It's a different location. And the Toronto Police and Ontario DREs put on one in Ontario as well. That is kind of the gold standard for maintaining our current um, keeping up with current trends and what's being seen across both Canada and the US. And so that is part of that 8 hours continued education that is expected. And that 8 hours also has to be approved. So it's not like I could say, well, I talked about this for an hour, there's 1 hour. There has to be some learning component to it that our national oversight approves that that course met the standards. So there's constantly training evolving and lots of communication from our national oversight with updates, as well as all of us. This is a passion, so reading things like the University of Saskatchewan study that came out, and just trying to stay on top of all those things.
Okay, great.
Yeah.
Yeah, so one person wondered about whether there's certain drugs that are difficult to detect. She noted that with cannabis, there were few signs if they were just strictly on that one drug. Can you comment on that?
There are some that are a little bit more difficult, especially um, with some of the higher levels of THC. We're starting to see a lot of psychosis. We're starting to see extreme paranoia, hallucinations, and they can almost present like a hallucinogen. And so that's where we're trained to be very careful in things like that reaction to light, measuring those pupil sizes, because that's going to help us differentiate between the two. And then there are some times where, for instance, if someone is on a stimulant for a long period of time and they come before me as a drug recognition expert as they're coming off of that stimulant has been keeping them up high there for however long, and their whole time their body is trying to slow them down, and their hormones and are trying to say like, whoa, our heart's too fast. We need to slow ourselves down. And so as that stimulant wears off, the body that has been trying to correct itself now has overcompensated. And so a lot of times what we'll see as a DRE is we'll see what we call that downside or that crash side. And it actually presents as if it's a narcotic. So that's why that interview with the officer is very important, because they probably saw that person way up here. And in the meantime, they're now seeing someone that is presenting very, very different, exact opposite.
Okay, very good. And actually, that brings us, maybe you can just finish on this one note, the
Yeah.
most memorable stop that you've ever had. And just before you answer that, just a reminder to everyone to please share our link for our webinars with your colleagues. And also, this webinar will be, well, it has been recorded and it'll be posted within the next few days. So we invite you, if you missed something, to look at that. So yeah, just as a closing thought, the most memorable stop that you've had.
Thank you for giving me the moment to think.
No
um,
problem.
Probably the most memorable I had uh, was a person who was on a stimulant, and they were in park but revving the engine, thinking they were driving like a race car track. Essentially, they were in a race but in park, going nowhere, engine revving, and they were absolutely astounded that I could keep up with their vehicle.
Oh my gosh.
Yeah.
Funny. That's a good one. That's a good
Yep.
one. Well, on that note, thank you so much. This has been extremely informative. I've received a lot of comments about excellent presentation. I think just because you did spend so much time and detail, but not too much. I mean, you kept it within what we gave you, but it just yeah, you gave an excellent overview. And I think if anybody didn't know what a DRE is before, they definitely do now. So, maybe we'll get you back someday to give other aspects of your work. But
Sounds good.
yeah, so thank you so much. Really
Thank
appreciate
you.
it, Shannon. Okay,
All
you have a
right.
great rest of your day.
Take care, everyone.